My capstone presentation is on mental illness and mismatched treatment goals, the incompatibility of biomedicine and the lived experience of stroke patients. First, I'd like to start by talking about my motivation to pursue this topic. When I was 17, I had an ischemic stroke. I felt alienated by my healthcare providers, and I found that my concern was graduating high school and going to college, but my doctor's goal seemed to be to make sure that I was stable enough to go home. So after some scans and some observations, I was sent home with a few follow-up appointments, but that was about it for my care. I ended up developing post-traumatic stress disorder, and interestingly enough, at no point was my mental health care or the trauma I just went through addressed by any of my practitioners. So my goal for this project was to find answers. Did I have a normal stroke experience? And if so, how can that be improved? In my research of biomedicine and stroke, I found that the medical system is incompatible with the lived experience of stroke patients. The goals of biomedicine and patients are fundamentally at odds with each other. While biomedical practitioners seek to stabilize and rehabilitate individuals up to the limits of biomedicine, patients desire care that goes beyond these limits. However, they are not asking for treatment that is impossible under any circumstances, but just under biomedicine. Throughout this presentation, I will show this argument by addressing the mismatched treatment goals of patients and their biomedical practitioners, as well as discussing the disproportionate rates of mental illness that exist in patients of stroke. Biomedical definition of stroke, according to Johns Hopkins University, is an event in which the blood flow is cut off to sections of the brain. This can damage or kill neurons and cause people to lose brain function. There are two types of strokes, ischemic and hemorrhagic, with ischemic strokes being much more common. It is important to note that the damage caused by stroke may be permanent even with the best treatment. And on the right side of the screen you can see an image of my brain. That's what an ischemic stroke looks like. Strokes are relatively common in the United States. It's the third leading cause of death in the country and the leading cause of disability. 795,000 people have strokes in 1 year, and 137,000 people die from strokes. As a result of these statistics, stroke and its consequences are deserving of our attention, and the adequacy of standard treatment is important to discuss. The standard biomedical treatment of stroke consists of an examination, imaging scans, drug therapies, close monitoring, and rehabilitation. In severe cases, surgery may be necessary. Interestingly, acute treatment plans lack any mention of mental health care, despite acknowledging the mental trauma that is caused by the event. In long-term care, it is mentioned as other care, but is not given the same detailed description that somatic interventions are given throughout the discussion. The consequences of stroke are far-reaching. Brain damage can cause a loss of brain function, with the downstream effect being losses of mobility, speech, and cognition. The loss of these functions can threaten a stroke survivor's identity. People lose their ability to participate in the social roles that give their life meaning. They see changes in their personality and have an overall dehumanizing experience. As a result of being reduced to a machine and the metaphor of biomedicine, a topic that I will cover next, patients lose their independence, which is a vital aspect of Western identities. Stroke survivors also develop mental illnesses at rates disproportionate to the general population as a result of the consequences of stroke and the failures of biomedicine to address these consequences. Biomedicine is a medical system that focuses on the biological aspects of illness. It centers around a separation of the mind and body, which is problematic in the case of stroke because it prevents the whole patient and their experience from being treated. It is a system that is prided as being transcendent from the culture within which it exists, but it is filled with Western values that emphasize productivity and independence. It also seeks to cure and fix the body, similar to how a mechanic seeks to repair a broken machine. However, biomedicine fails to achieve this goal as there is no cure for stroke. The goals of stroke survivors and biomedical practitioners are oppositional. While patients desire a full restoration of their pre-stroke lifestyle, the goal of practitioners is to treat the initial stroke by stabilizing the patient and preventing recurrent strokes. This creates tension in the biomedical system as patients expect an outcome that is beyond the limits of biomedicine. Those mismatched treatment goals stem from the different understandings of the trajectory of the stroke experience. Patients believe in the ability of biomedicine to cure all medical issues. As a result, they expect to recover fully through participating in recovery efforts that include rehab. Through hard work, they believe that they are able to achieve their goal. This applies the Protestant work ethic that is prevalent in the United States to stroke. In contrast, biomedical practitioners only anticipate a partial recovery of the patients. Recovery depends on spontaneous recovery of the brain and stimulated recovery from rehabilitation efforts. Biomedical practitioners only anticipate this partial recovery because they know that the spontaneous recovery of the brain drives the process and it is limited and not infinite. They also see the limits of biomedical interventions and recognize that there is no cure for consequences of stroke. Patients, on the other hand, view rehabilitation as the cure. They believe that they are able to recover entirely by participating in the process. But when this doesn't happen and biomedical care is terminated, patients develop additional mental illnesses. Stroke patients develop mental illnesses as a result of the failures of biomedicine in addition to the initial trauma of the stroke event. Rehabilitation efforts emphasize the effort of the patient in driving recovery, despite the fact that spontaneous recovery is responsible for most of their improvement. In combination with the loss of function brought on by stroke, patients' perceived failure to cure themselves leads to depression in survivors of stroke. The uncertainty of the trajectory, driven by the vagueness of biomedical practitioners' predictions, leads to the development of anxiety. And the trauma endured at the onset of the stroke and through the treatment process can lead to the development of PTSD. Stroke patients develop these mental illnesses at a higher rate than people do in the general population of the United States. 25 to 33% of stroke patients will develop a mental illness after stroke, in comparison to 18.9% of adults in the general population and 13.8% in adults over 60 years old, which is the age at which people more commonly begin to have strokes. Mental illness is problematic because it corresponds with lower quality of life. This means that stroke survivors have a disproportionately lower quality of life as a direct result of their strokes and biomedical treatment. Major depression is one of the three most common mental illnesses associated with stroke. Between 17% and 25% of stroke patients will develop post-stroke depression. In comparison, only 7.1% of the general population and 4.7 adults over the age of 50 will experience major depression throughout their lives. Depression is associated with the loss of function from stroke and the patient's perceived failure during rehabilitation. The loss of identity caused by the inability to participate in their daily lives and to participate in society is a key factor. Additionally, the fact that biomedicine frames rehabilitation as something that is driven by the patient instead of by spontaneous recovery leads patients to feel as if they failed when they stop improving and care is terminated. This also serves to absolve responsibility in recovery from the biomedical practitioner and instead places the responsibility on the patient. Depression can reduce recovery in stroke patients as it may give them difficulty sleeping. With less sleep, patients experience less cognitive recovery. This shows that in the case of depression, biomedicine is counterintuitive to its own goals. Between 18 to 25% of stroke patients will develop post-stroke anxiety, and 21% of these patients report moderate to severe symptoms. In comparison, in the general population, 31.1% of adults will experience anxiety at some point in their lifetimes. Only 9% of adults over the age of 60 experience anxiety. Post-stroke anxiety in these patients is caused by the uncertainty in the trajectory of stroke and the vagueness of practitioners in their predictions. Because spontaneous recovery is out of the control of patients and practitioners alike, patients face many unknowns that can lead to the development of anxiety. Finally, 13 to 18% of stroke patients develop post-traumatic stress disorder. Only 6.8% of the general population in the United States develops PTSD at some point in their lives, and only 1% of adults over the age of 50 experience these symptoms. Post-stroke PTSD can be caused by the initial trauma of the stroke. The combination of a life-threatening medical experience, its abrupt onset, and the sudden loss of functionality can cause the disorder. PTSD increases the risk of recurrent strokes because it coincides with avoidance and numbing behaviors that are linked to stroke. For example, patients may avoid medications and participate in behaviors like drinking and smoking that further deteriorate their health. The biomedical treatment of stroke can be made adequate by adopting a more holistic approach. Instead of only treating patients using somatic interventions, the body and mind should be treated together and the patient should be part of the healthcare team. Education on the limits of biomedicine should also be increased. Instead of being given vague answers on their trajectory, patients should be educated more honestly on the limits of rehabilitation and on the difference between spontaneous and stimulated recovery. This can reduce the feeling of failure in patients at the end of their rehabilitation. Patients should also receive education on how they can compensate for their functional losses to return as much as possible to their daily lives. When compensation is not possible, mental health care becomes much more important. This should be provided in acute care and continue onward through treatment. This would help patients cope with their trauma and the losses that they endure. Patients should also be screened for mental illness. PROMIS and neuro quality of life testing are two types of tests that draw on the patient perspective throughout the stroke recovery process. They ask patients to rate themselves in areas concerning disability, ability to participate in social roles, and other measures of their quality of life. This provides a different picture than the assessment of biomedical practitioners and can aid in the detection of mental illness. Expanding and standardizing these tests can provide a way for these concerns to be addressed that still fits into biomedicine's preference for measurable numbers and statistics. To conclude this presentation, I'd like to reiterate my main argument. Biomedicine is fundamentally incompatible with the patient experience. While patients emphasize the social consequences of stroke, biomedicine focuses on its physiological consequences. Both perspectives are important to a patient's health and well-being, but they should be addressed together rather than separately. The failure of biomedicine to consider patient concerns contributes to the development of mental illnesses at disproportionate rates when compared to the general population. These illnesses tend to include depression, anxiety, and post-traumatic stress disorder. Improvement of the treatment process should focus on incorporating patient desires in the social consequences of stroke. This can be done by expanding on PROMIS and neuro quality of life testing that quantify patient perspectives in a way that fits in with biomedicine. Additionally, mental health care should become standard practice for stroke patients that receives the same level of urgency and dedication as the somatic interventions for stroke. Finally, here are the references that I've cited throughout my presentation. Thank you for watching.